Nito ko tetutietab tililindo ole inyorune logoiwek tugul chetinyegei ak kanyoiset cheboto kanetisiosiek chetoretin eng teretab mionwogik.
I am Dr. Anjumanara Omar.
Eng kainaik kekureno Luke Kipruto Arap Tuitoek.
My name is Dr. Justine Jolagato-Dioni.
My name is Dr. Waweru Monyo.
My name is Dr. Issa Moshey.
I am Dr. Shrikant Dalwadi.
My name is Dr. Frederick Kairibia.
My name is Dr. Beatrice Nganso.
Testai iker tetutietab tililindo eng KASS TV amu kimnatet naet.
My name is Dr. Issa Moshey. I'm a consultant obstetrician and gynecologist. We mostly go by the second part gynecologist, but it entails both of those two. We are also known as reproductive health specialists. We mostly deal with women reproductive health. However, occasionally we do encounter quite a number of male patients that come to us with reproductive health issues. What we mainly focus on in terms of my specialty is just generally, like I had said, women's reproductive health. So it entails both the aspects of pregnancy and also reproductive health related issues, including things such as, uterine fibroids, sexually transmitted infection, contraception, family planning, otherwise known as contraception. We also deal with issues to do with gynecologic cancers, that is cancers of the reproductive systems, particularly for the female, the women, that is. So that is generally a description of who I am and what my specialty is. I did my undergraduate studies in Turkey at a university called Gazi University back in the 2000s. And then I did my master's, that is the specialization to become a gynecologist. I did it at Moi University School of Medicine. And I'm now glad to be working for Topil Hospital as one of the 2 resident gynecologists here. So maternity care entails follow-up of patients who happen to be pregnant. That is from the moment they are pregnant to the point that they've delivered, and not just after delivery. It also goes all the way to what is known as the postpartum period. That is roughly around 6 weeks, roughly 1.5 to 2 months after the delivery. That is what maternity care entails, and that is the work of an obstetrician, which is part of my specialty. So maternity care is basically, otherwise known as antenatal care, is basically meant to ensure that the health of a pregnant woman is actually well maintained, and the health of ensuring that the health of a pregnant woman is maintained and followed up. It means it's also ensuring the health of the baby that they are about to give birth to is also monitored and ensured, so that we have a healthy baby or babies born into this world. So most people, when we talk of maternity care, they just assume we deal with the pregnancy or the pregnant women, but it's also something that starts from what is known as preconception care. That is, before a woman even attempts to get a pregnancy, we should actually be following them up so that we make sure that they are optimized and they are of healthy status, so that by the time they are getting pregnant, everything is under control, so that the pregnancy in itself will be as smooth as possible, as opposed to someone who gets pregnant without planning or without preconception care and eventually might end up having complications. So a good maternity follow-up or maternity care will start with preconception care. That is, before the woman even anticipates or plans to get pregnant, they need to be under the care of an obstetrician and gynecologist, so that we ensure that they are of the best health possible before they get pregnant. So what does preconception care entails? We ensure that if a woman has medical conditions such as hypertension, diabetes, epilepsy, HIV, to say the least, these conditions are actually under control before they even try to get pregnant, because pregnancy complications, while having these diseases or these conditions at the same time, might actually be on the rise or increase if they are not under control before that woman gets pregnant. So it means we review their health status. If they are on any medication, we try to make sure that those medications are actually not harmful to the baby should they get pregnant, in case they are using any medication. For example, patients with hypertensive disease use medications such as losartan, such as enalapril. These are not medications that we would like for them to use during pregnancy. However, we cannot stop antihypertensives or the blood pressure medications because we are anticipating a pregnancy. So what can we do? We normally change them to more friendly or more pregnancy friendly medications, so that should they get pregnant, at least those medications will not be harmful to the baby. So that is all about preconception, just a brief description of preconception care. Now when we move to now the antenatal care, that is the maternity care itself, the most commonly asked question is our patients normally, or our clients normally ask us, when should I start going to the clinic when I discover that I'm pregnant? Now, I have two answers for this question. It depends on the type of patient you are. There are patients who already are high risk, or they have high risk pregnancies. And what are high risk pregnancies? Like I had mentioned, if you have someone who has medical conditions such as high blood pressure, diabetes, HIV positive patients, or any chronic illness, once they become pregnant, then this automatically becomes a high risk pregnancy, which means it needs to be followed up very early on, as opposed to other women who are of average risk, who might start the clinic a bit later compared to these ones. So these ones, the minute they discover they're pregnant, it's always advised for them to start the clinic immediately. Not at 3 months, not at 4 months, but immediately they miss their period, they do the test and discover they're pregnant, it's advisable they start maternity care or antenatal care immediately. For an average risk woman or an average risk patient, we normally would like for them to start in the first trimester, anytime in the first trimester. And what is the first trimester? If you are to look at a pregnancy in layman's term, it's 9 months. For us, we normally describe it in terms of weeks. We say a full pregnancy goes around 40 weeks. So first trimester, if you are to divide the pregnancy, the 9 months into 3 months, we have what are known as trimesters. That is, each third of the 9 months is known as a trimester. So it's advisable for the average risk woman to start their clinics, or rather obstetric or antenatal visits, in the first trimester. That is, within the first 3 months of the pregnancy is when you're supposed to start the first antenatal visit. And the reason why we insist mostly in starting these clinics very early on, as opposed to what is commonly done by most pregnant women, that is starting around 5-6 months, is because there are certain issues that we can address early on to optimize the pregnancy, so that we minimize the risk of complications further. The other reason why we would wish for them to start this clinic very early is because we also do the investigations for pregnancy at this point. Should we discover anything that needs addressing, we address it. We also do an obstetric ultrasound, that is the ultrasound commonly known as Pichaya mimba. So we will do that one in the first trimester, preferably roughly around 2 to 3 months of the pregnancy is when we do the first ultrasound for all pregnant women. And one of the benefits of doing this ultrasound very early is the fact that it's more accurate in terms of telling us how far the pregnancy is, as opposed to doing an ultrasound 5-6 months later, in as much as we can still use that one, but in terms of dating the pregnancy. And this is more specific for those individuals, or those women who are not really sure about their last period, for us to use that to calculate the how far along they are in the pregnancy. So that first scan, the earlier it is done, the more accurate it is for us to know how far exactly that pregnancy is in terms of the weeks of that pregnancy. The benefit of doing an ultrasound very early in the pregnancy is also, if you were to determine if it's a twin pregnancy, this is the best time, because it's not just knowing if they are twins, but the types of twins. There are different types of twins that we normally deal with. So the best time to discover or to determine the types of twins via the ultrasound, that is the picture that is normally done, is normally this first trimester, one of the most accurate things. Another reason why a very early scan, particularly in the first 2 to 3 months of the pregnancy, is needed is especially for these women who have a high risk for certain conditions. For example, if you have a history of recurrent pregnancy losses, particularly early pregnancy losses, or you have a history of what is known as an ectopic pregnancy in the past, that is the pregnancy that has not grown inside the uterus but outside of the uterus, or if you have a history of something known as a molar pregnancy, it's a pregnancy that is not necessarily formed the way it's supposed to form. So these are the kinds of things you really need to do the ultrasound very early on in the pregnancy, so that you are certain that it's not recurring, because once something has occurred in the past pregnancy, there is a risk of it recurring in the future pregnancy. So you want to do this ultrasound very early on, so that you kind of get reassured that this is now a normal pregnancy as opposed to what was happening in the previous pregnancy. And should we discover that it's not a normal pregnancy, then we get to address that one, as opposed to having a woman waiting months down the line only for them to discover very late or later on that it's actually not really a normal pregnancy they're carrying, that would warrant termination of that pregnancy very later on, as opposed to doing that in a safe environment earlier during that pregnancy. So that first ultrasound is very important for us. We also address numerous issues during that first antenatal visit within the first trimester, including the weight of the patient, because there is a certain amount of weight we normally track women. We don't want them to either gain so much of weight during the pregnancy or not gain weight the way they're supposed to during that pregnancy. So we need to find a balance in terms of the weight during that pregnancy, and that first visit normally helps us in doing that, which means we also address issues with nutrition. In the first visit, we also talk about family planning. It's very important. One might ask, why are we discussing family planning while someone is pregnant? It's just in preparation. Once you've delivered that baby that you're carrying, what is your next plan? Would you wish to get pregnant immediately? Would you wish to wait a couple of years so that at least more time is given to this new baby that you've had? So those are some of the things we discuss in the first antenatal visit. We also try to screen for issues with mental health status of the woman, because pregnancy might be a bit of a stressful period for some women, so we want to ensure that they are not necessarily going through things mentally that might actually be detrimental both to their health and the health of the baby they're about to give birth to. We also deal with issues with gender-based violence, because sadly this is the period where quite a number of domestic violence cases are reported to healthcare professionals. So we screen these women and I'm talking about women, but it's more of a couple, because most of our patients do come with their husbands, with their partners, as opposed to women coming just by themselves towards these clinics. Besides that, we also deal with issues to do with sexual health, because in as much as someone is pregnant, and this might vary according to certain cultures, but we also encourage continuing with sexual intercourse with your partner in a safe manner during this pregnancy period. Just because someone is pregnant does not necessarily mean that they might not necessarily continuing having that sexual encounter with their partner, unless there are very few circumstances that we try to avoid that in certain patients, but for the majority of the patients it's actually a healthy thing to go on about. So that is what we normally discuss in the first visit, which should happen, and I reiterate, in the first trimester. Ideally, when the pregnancy is around 2 to 3 months is when we do all of these things. Of course, besides this, we also do the lab investigations, whereby blood and urine is drawn, so that we do a series of tests that we do routinely in all pregnant women. So these include a complete blood count. We see if the patient is already anemic, that is, there's low blood levels, and if so, we normally give them medications to boost up their hemoglobin, that is the blood levels. We also do blood group. It's very important for us, in as much as most women might not necessarily know their blood group. We do that test in the first visit. We do a urine test to figure out whether there is any problems or any infection in the urinary tract system. We also do HIV test, syphilis test, and hepatitis B test, because these are very important to us, not just for the pregnant woman, but also to the baby they are carrying, so that should they be having these illnesses, we try to reduce the risk of the pregnant woman transmitting that infection to the unborn child or the baby once they are born. Last but not least, we also do I think I've mentioned all the necessary tests that we normally do, and of course, depending on the risk, for example, those who are coming from a malaria endemic region, where an area where malaria is very rampant, we do a malaria test. We do a random blood sugar test just to screen so that we see if someone has elevated blood sugar levels that could indicate maybe they have diabetes without them knowing. We check the blood pressure of that woman in that first visit so that we ensure she's not already starting their pregnancy with elevated blood sugar levels. And we've diagnosed quite a number of patients, or rather pregnant women with these conditions that they had no idea that they already had them, which is why we normally say pregnant women or women in general are healthier than men, because the number of health visits they have during their lifetimes is more compared to men, because pregnancy forces them to start clinics, and these tests are normally done in women as opposed to a man just walking voluntarily into a clinic without any illness, which is a rare occurrence. So that is as far as the first visit. Another question that we are normally asked, how frequent should I be seen during the pregnancy? So according to the World Health Organization, which sets guidelines for most of our clinical practices, initially they had recommended a minimum, and this is not a maximum, minimum of 4 visits. However, this number has been reviewed to 8. So during pregnancy, the number of antenatal visits that a woman should be a minimum of 8 visits. This is roughly every month of that pregnancy, you need to be seen once. And this is not for every pregnant woman. This is for the average risk woman. So if you have a high risk, for example, you have diabetes, you have high blood pressure, you are a HIV patient, or you have a bad obstetric or pregnancy history, maybe you had complicated pregnancies in the past, we may review these visits. Instead of 8, we can even have more visits based on the need of that patient. This is not to say that since you've been seen last month, you cannot come and see your obstetrician if the need be. For example, if you encounter any problem during that pregnancy, you should always contact your doctor so that you organize for an appointment, you get seen immediately, as opposed to waiting for a month before your next visit. Another question that we normally we get a lot is, how many ultrasounds can a woman do during pregnancy? So we normally say as much as possible. However, the bare minimum that each pregnant woman should have in terms of the ultrasound, just to see if the baby is doing well and whatnot, is normally a minimum of 3 scans during the pregnancy. So the first one, like I had mentioned in the first antenatal visit, roughly we do it around 10 to 12 weeks. That is roughly around 2.5, 3 months is when we do the first ultrasound. For some pregnant women, we might do it early, especially those with a higher risk that we had mentioned earlier. The second ultrasound that we normally do is what is known as an anomaly scan or an anatomy scan. We do this one around 18 to 22 weeks. So that is roughly around 4.5, 5 months is when we do the second ultrasound. And this is generally to check up the well-being of the baby. Are there any malformations that this baby might be carrying that we can detect early on during that pregnancy? And as early as this second ultrasound, that is around 18 to 22 weeks, sometimes we can even tell the gender of the baby if our patient is interested in knowing that one. The final ultrasound that we do in the average risk pregnancy, that is a normal woman without any high risk who happens to be pregnant, is normally done around 34 to 36 weeks there. That is the final ultrasound that we normally do, just to check if the baby is grown well, if there are any issues that might need to be addressed, that might even tell us whether this woman might need to be delivered via cesarean section or a normal delivery. So that is the third scan that we do. However, the women with high risk, we might do scans as frequent as need be. In fact, for some women, even as frequent as every 2 weeks. We've been having such patients that we've had to, do those scans more frequently. So that is as far as the ultrasounds are done. Another question is, when should I anticipate my delivery, or at what gestation, or how many weeks of the pregnancy? So I know in layman terms we normally talk of a pregnancy to be 9 months, but in actual sense it's almost 10 months if you do the calculations. A normal pregnancy generally takes roughly 280 days, which is roughly 40 weeks, which is roughly the 9.5, 10 months if you do your calculations well. So for most of us, when we do the calculation using your last period, and by the time we do that, it gives us, what is known as an EDD, the estimated date of delivery. That is basically the day you are actually going to be 40 weeks, and we anticipate that most women would have gone into labor by that time. However, it's not unusual to have some women who might go beyond that 40 weeks, the EDD, the death that they've been told they are going to be delivered, most of our current practice, normally we will induce these women. Once you reach your EDD and you've not gone into labor, we prefer inducing you. However, there are certain women who would wish, and clients who would wish to wait for a few days, and we see if they still go into labor or not. So the maximum we can allow them to go beyond that EDD, the estimated date of delivery, is a week, so that they can go all the way to 41 weeks. If they've not gone into labor, then we can for sure advise them to come for induction of labor, so that they don't go beyond that one, because a pregnancy that goes beyond that period has risks, including the loss of a child, which is not something that we would really want to experience, hence why we insist on inducing at 41 weeks. So preconception, the word pre means before something. So preconception means before conception. It means you want to have health issues addressed before someone even gets pregnant. And I had mentioned this ideally should be for all women of the reproductive health who are in preparation or who are not using contraception, who are sexually active. They should assume that at any given point they can get pregnant, which means they need to be of a health status that actually is conducive enough to carry a pregnancy safely, which might not, which will not result in a detrimental health effect on both the woman and also the baby, should they be born under such circumstances. So basically, preconception care is ideally something that is offered to all women of the reproductive age group who are engaged in sexual intercourse, particularly unprotected sexual intercourse, without using contraception. We assume that they can get pregnant at any point, so we need for them to have a healthy status for them. Should they get pregnant, they should not have these pregnancy complications that we're dealing with, and their baby also will not have, might not necessarily get affected by the mother's health status. So what are some of these things we normally look at? Most of the times, it's very rare that you find a patient or a client just walking in without any health concerns, coming to ask us, or rather to just come for a checkup before getting pregnant. Most of the ones that we see are women who will eventually probably have high-risk pregnancy. So we have women such as those with hypertensive disease, so a woman who already has a high blood pressure, someone with diabetes. So this is someone before they even get pregnant, they are diabetic. Women with living with HIV, or it might not necessarily even be the woman per se, but their partner might be HIV positive and they themselves are negative, what is known as a discordant couple. So this is just to mention but a few of the number of, or rather the women who come to us before they get pregnant and they are preparing themselves to get pregnant. So they just come for a checkup to get, like, so to speak, a clean bill of health before they go on. Other conditions that we normally see in the preconception are people like epilepsy, because these are women who are on long-term medication use. Some patients such as those with sickle cell disease, there are patients with kidney disease. So these are the ones who have health conditions and are using medications that might be harmful to a baby should they get pregnant. So once they come to us in that preconception care, first and foremost, we do what is known as a multidisciplinary management or assessment, whereby I, as the obstetrician, together with the physician who's seeing these women, for example, if it's a hypertensive woman, their physician who takes care of the high blood pressure will be collaborating with me to make sure that the blood pressure of this woman is well controlled before she even gets pregnant. And if she's using medications, then these medications we want to ensure, like I had mentioned earlier, that these medications are compatible with pregnancy. They're not medications that might harm the baby, because we have quite a number of medications that women might be using without knowing that should you get pregnant while you're using this medication, you might have an increased risk of delivering or carrying a child who has malformations, including heart malformations, kidney malformations, even neural malformations, that is, the brain is underdeveloped, and such like things. So part of the function of that preconception care is to first and foremost make sure that if you have a condition, it's well controlled. If you're using any medication, then we are using the kind of medications that are, conducive, or rather are not harmful to the baby. And last but not least, we also want to make sure that they are already on vitamins, that is particularly one that is known as folic acid, that is normally very important in the first weeks of pregnancy. So we ensure that before they even start the they get pregnant, they are on these prenatal vitamins, so that should they get pregnant, at least they've already been started on that one. So that is just roughly what preconception care entails. So rhesus factor, particularly the women who we are concerned about pertaining to pregnancies, are those who are rhesus negative. That is, their blood group is rhesus negative. So you'll notice when we talk of someone's blood group, you'll hear someone say, I'm blood group O, and then there is a positive or a negative that comes after that. They'll tell you I'm blood group AB, positive or negative. So the ones that we are concerned about, their rhesus factor, that negative or positive, are those who happen to be negative, because that kind of pregnancy carries a certain risk, and not so much for the pregnant woman themselves, but for the baby that they'll be carrying particularly. And you'll notice that for those who are rhesus negative who get affected by that status, it's usually the first pregnancy might be a very normal one, anazaa mtoto kawaida, and then the next ones are the ones that you find babies are getting affected. Either they have very early deliveries, early miscarriages, or they give birth to baby that have certain features that are not so much considered to be normal features because of that effect. So the women that we are concerned about, and this is why we want to do the blood group for these women in the first antenatal visit, is to ensure that they are not rhesus negative. If they are rhesus negative, then we start monitoring them very closely, so that should something happen throughout that pregnancy, then we can do what is known as risk mitigation. It doesn't mean that if your blood group is rhesus negative, you are guaranteed to get these complications, but it's something that is quite a risky affair, especially if you are rhesus negative and your husband or your partner is rhesus positive. If you're rhesus negative and your partner is rhesus negative also, which is why it's also encouraged when you're, seeking partnership or you're getting married or whatnot, it's good to know your husband's blood group, so that you have this settled that. So that if your husband is rhesus positive and you are rhesus negative, you should be very careful when you get pregnant, you get monitored closely. High blood pressure, we can talk of two types of high blood pressure. There's the high blood pressure that exists before someone gets pregnant. So this is a patient or a woman who is already having hypertensive disorder, that is high BPs, before they even got pregnant. So it's not to say that the pregnancy caused this high blood pressure, it's something they already had. And the other group of patients are those who start the pregnancy very well, the blood pressure is very okay, and before the pregnancy they've been known to be having normal blood pressures, but throughout the course of the pregnancy they start developing high blood pressure, that is, the blood pressure goes high. And remember, during pregnancy actually it's the opposite. For a normal pregnancy, the blood pressure actually goes lower than what is expected. For example, the average blood pressure of someone, you and I, or even any other woman who's not pregnant, is roughly 120/80. So during pregnancy, you find it going even lower than that. It goes around 110, 100/80/70, around there. So there is a slight hypotensive reduction of blood pressure. Now, to get someone whose blood pressure is actually going the opposite direction and is increasing, means something might not necessarily be going on well, and this is a patient that needs to be monitored closely. So this type of blood pressure that increases during pregnancy is what is known as pregnancy-induced hypertension. So this is someone who was okay before the pregnancy, and then all of a sudden during the pregnancy we start noticing the blood pressure going up. We call that pregnancy-induced hypertension. And there are different kinds of this pregnancy-induced hypertension. We have the most common one that most women are even aware of, known as preeclampsia. We have another one called gestational hypertension. So there are various criteria that we normally use to establish which one is gestational hypertension, which one is pregnancy-induced hypertension. And these high blood pressures, generally you'll find them, they come 20 weeks upwards. It's not something you'll commonly discover in a woman who's 1 month, 2 months pregnant. If you discover a woman who's 1 month, 2 months pregnant and the blood pressure is elevated, then it's very likely that this high blood pressure was already existing before they even got pregnant. But once someone gets to 20 weeks, that is roughly around 5 months pregnant and above, 4.5, 5 months, and the blood pressure now starts increasing, is when now we start suspecting this is very likely to be pregnancy-induced hypertension. And the most common one in this scenario is what is known as preeclampsia. Now this is a very risky condition to have during pregnancy, especially if it starts very early on, because it's a condition that affects multiple organs in the body of the pregnant woman in terms of the complications that the pregnant woman themselves they might get. So you might find the heart might be affected, the liver might be affected, the kidneys might be affected. Sometimes the brain is also affected to the point that you find women get what is known as seizures or eclampsia. That is, they are convulsing during that pregnancy. It's because of that high blood pressure. So the earlier it starts, the more dangerous, the more risky it is, and it's a pregnancy that might need to be monitored, actually absolutely needs to be monitored very closely. So quite a number of these patients, actually, once we've established they have this preeclampsia, that is the pregnancy-induced hypertension type, we might either manage them as outpatient or inpatients, that is they are admitted throughout the pregnancy depending on how severe that condition is. So for those without what is known as severe features, we can just be monitoring them very closely. Every 2 weeks they are seen at the clinic and they get to go home on medication. But for those with severe features, we normally admit them to the hospital, and sometimes all the way till delivery, and very likely this delivery is going to have to be early on. So instead of going all the way to 40 weeks, we have to deliver them very early, and sometimes we try to prolong that pregnancy so that the baby matures, the lungs mature, so that we don't have issues with complications of prematurity. However, we can only push that one as far as 34 weeks. There are scenarios where we are forced to actually deliver them very early on, because when it comes to obstetric care, our first priority becomes the mother. So we might not necessarily prolong that pregnancy for the sake of the baby if the mother is getting worse and worse and worse. So in those scenarios, unfortunately, there have been moments where we've had to do what is known as termination of pregnancy or early delivery if it's something that is a bit more advanced. So those are some of the issues we have to deal with when it comes to hypertensive disorder. It's something that means you really need to be having these clinic visits very early, so that should we discover your blood pressure is showing a trajectory where it's elevating, it's rising and whatnot, we start doing investigations very early on. We probably even give you medications that will reduce the risk of your that blood pressure elevating further and forming what is known as developing preeclampsia and whatnot. So those are some of the complications for the mother. We've had women who've had that condition, preeclampsia, who've bled into their brains because of those convulsions. We've had women who've had their livers rupturing because of complications of that condition known as preeclampsia. We've had women who've had to go through dialysis because their kidneys have failed because of this hypertensive disease of pregnancy known as preeclampsia. So it's something that is quite detrimental to the mother. How about the baby? How does the high blood pressure affect the baby? So one of the most common complications is you get a baby that is not maturing or developing well. Growth is not so optimum. So you might find someone who is delivering a baby at 9 months, but the baby is 2 kilograms or 1.5 kilograms. So that is known as a feature known as fetal growth restriction, because that high blood pressure brings certain changes to the placenta that do not allow for the optimum or normal growth of that baby, of that fetus while inside the uterus. Another complication might be these babies themselves whose mothers were having high blood pressure during their pregnancy. In the future, once they are born, themselves have a risk of developing high blood pressure. And then there's a risk of, and this is something that comes with prematurity, because most of these babies have to be delivered premature. Around 7 months, 8 months is when they are delivered for those who are stable enough. So you can imagine the issues that come prematurity these babies might have them, including things with respiratory issues, including things to do with developmental issues, that is their brains might be underdeveloped and such like things. So basically it's not a condition that just affects the mother, it affects both the mother and the baby, and sometimes unfortunately catastrophically to the point we end up losing either of those two or even both mother and baby as a result of this. So it's something that is quite serious for us. First and foremost, the term normal delivery almost, in my opinion, stigmatizes cesarean delivery to make it sound like it's abnormal. Cesarean section is also a normal delivery for those patients who indeed do need it. So the term we use is cesarean delivery, and I don't know if I can use the word a vaginal delivery. So that is the terms we normally use, because when we use a normal delivery and someone has had a CS, they'll ask you, was mine abnormal? So it becomes a bit of stigmatizing term, if I may say so. So there is, each country has what is known as cesarean section rates that are normally published. That is the number of, if you had to take 100 women in that population, what percentage will deliver via cesarean section and what percentage will deliver vaginally or normally, so to speak. The recommended number is normally roughly around 15%, and this is according to WHO. That is, if you are to have 100 women, 15, a number that is close to 15 is reasonable for them to deliver. And these are women who do indeed need to be delivered via, method. However, this is not to say that this number may not change, because the needs also will change. For example, if you go to a place like Top Hill that sees quite a number of patients who might actually have serious conditions, or if you go to Moi Teaching and Referral Hospital, which is a referral facility that tends to get women with a lot of high risk pregnancies or with a lot of complications, it means in those facilities the rate of cesarean section might actually be high compared to a sub-county facility where they don't even see high risk pregnancies as much as we do over here. So that is not to say that going beyond that 15% is a bad thing. It depends on where you are. It depends on those women who are undergoing this cesarean delivery or cesarean section indeed going for that procedure, because they do indeed need that. And part of the reason why a number of women have to be delivered by cesarean section, the number one reason, according to our population, is normally labor that has failed to progress. So you find a woman who's been in labor 18, 24 hours, some even go up to 48 hours and they are not advancing, and that is something that is quite risky for both the pregnant woman and also the baby that they are carrying, to the point that we've had quite a number of them who've lost their babies during that labor that is prolonged. So these are women that should not be delayed. Those are the ones that should go for cesarean section. We have another, one of the most common causes is, for example, you might indeed be the labor is progressing on well, however the baby's heartbeat is not beating very well, what is known as fetal distress or non-reassuring fetal status. So if you discover that the baby's heartbeat, either it's so fast or it's beating so slowly, it means that baby is in danger, and we might not necessarily wait until they are delivered, because it might be a bit too late. So we might find ourselves rushing to take these women for a cesarean delivery. Other causes include like bleeding excessively during labor or even before labor. It includes things such as, for example, anything that tells us that the mother is not stable enough to go through a normal delivery, or the baby is not stable enough to go through the normal delivery, then we normally send them for cesarean delivery. Another reason why you'll find that the number of cesarean section rates, or rather the rate of cesarean section in our country, is also increasing, is because there are women who have already had cesarean deliveries. So these are the ones that if you have one cesarean delivery and you have been selected carefully, there is room for you to try normal delivery even after delivering by cesarean delivery, and there is a very good criteria for that one that I don't wish to get into right now. It's a bit too detailed. However, if you have more than one cesarean delivery, you've had 2 cesarean deliveries, automatically you cannot deliver. Normally you have to be, the rest of the pregnancies, you have to be delivering via CS. So this is why even you have quite a number of women who've delivered via CS in the past 1-2 times, which means automatically the numbers will go high. Of course, with these other conditions, that is high blood pressure, diabetes, quite a number of the times you'll find ourselves having to go for cesarean delivery, because the baby is most likely compromised, or the mother is also compromised due to a rise in these conditions, which means they also end up going for cesarean delivery. There is no maximum number of cesarean section that a woman can have. What a woman should understand is, with each cesarean delivery that you have, that is a cesarean section that you have, the risks that come with that surgery increase. So it's up to you to decide whether these are risks that you're willing to take, so that you decide this is enough or not. So we've had women who've even had 5 cesarean deliveries, 6 cesarean deliveries. However, these are very risky, high-risk pregnancies, because with each cesarean section comes a bunch of risks that might impact the woman and the child's health in the future. So there is no particular number that we say this is the maximum that you can have. Of course, the doctor might advise you. For example, you've had a patient who's going for a 3rd cesarean section. you want to counsel them and see if they still want to have more babies or not. In case they don't wish to, then we advise for methods of family planning, including the permanent ones, that is the TL. However, long story short, there is no maximum number of cesarean section that a woman can have. However, with each increased, especially the more you have, the more these risks do come, to the point that we've had women who have even lost their lives or have had to have their uteruses removed during that final cesarean section because of those complications that come with the more scars that you have. In the past, I used to hear a number being tossed. You are told 3 is the maximum or 5 is the maximum. So these days we don't generally tell women that. We just inform them that they have options. However, they should really consider these options when taking them. It's what is known as cesarean on maternal request. That is a woman who does not necessarily medically require a cesarean delivery, who is very much qualifying to have a normal delivery safely, who wishes to have a. So it's a controversial topic because it will depend on the doctor who's seeing that patient. If personally, it's something that I would counsel that woman carefully and tell them that cesarean section, and try to figure out why exactly they actually wish to have a cesarean section as opposed to a vaginal delivery. And one of the reasons mostly in anxiety, quite a number of anxiety and fear of labor itself. Sometimes it's someone who's already delivered in the past, and then they had quite some negative experiences that have brought about this fear and anxiety towards going again through that process. So you just try to establish the reasons for that patient to go through that. You explain to them that a normal or a vaginal delivery is always encouraged under optimal circumstances, that a cesarean section is not, so to speak, the easy way out, that there are options in pain management that are available, especially what is known as painless labor, whereby you can get an epidural anesthesia so that you minimize on the pain on during labor. So you address the causes, or rather the reasons behind this woman wishing to have a cesarean delivery where they might not necessarily wish to have. And then once you've addressed those issues, most of the times you'll find that they do once again go ahead with what they were fearing. However, there are those who will still insist they want to have a cesarean delivery. Then that becomes a matter of them and their doctor discussing the options that they can have, and also the insurance, especially if it's a patient that is using insurance, whether that insurance will permit or will even cater for the expenditure, or rather for payment of such a procedure in a woman who might have delivered normally and opted for that. So it's not a very easy question to answer. We have found ourselves in such a scenario where someone requests, and quite a number of times we've talked them out, or we've reassured them that a normal delivery could actually be quite something they could attempt. This is my sample, or rather mannequin of a uterus, a female reproductive system. If I may open it like this. So this is our model of the female reproductive organs or tract. Here we have a uterus. This is the right tube or fallopian tube. This is the left fallopian tube. And right over here we have two structures known as the ovaries. We have the right ovary and the left ovary. So how does a pregnancy form? For us to understand an ectopic pregnancy and how an ectopic pregnancy forms, we need to understand how a normal pregnancy comes about. You have intercourse with your partner. Sperm is deposited over here. It ascends upwards through the cervix into the uterus, and it passes through to the tube. At the same time, if it's a specific time of the month for the woman whereby they've ovulated, the ovum escapes this ovary and it enters the tube, goes inside the tube, and if that woman happens to have had intercourse during that time of the month, unprotected intercourse, that is, the sperm that has been deposited by the sexual partner or the husband will meet this ovum that has come over here after ovulation, and fertilization will generally occur inside this tube over here at a place known as the ampulla of the tube. Once that fertilization has occurred, that pregnancy, or rather the fertilized egg or ovum, will be transported all the way inside into the uterus and will implant inside the uterus to form what is known as an intrauterine pregnancy, which is a normal pregnancy that has grown inside the uterus, okay? and then it will keep on going over and over for a period of up to 40 weeks gestation. Now, what is an ectopic pregnancy? An ectopic pregnancy is simply a pregnancy that is extrauterine. Remember, this one that we've described earlier was intrauterine, inside the uterus. Extra means it's a pregnancy that has grown outside of the uterine cavity where we expect it to grow. So instead of it being over here, it might be within the tube, it might be in the ovary, or anywhere inside the pelvic cavity or abdominal cavity, including in very rare circumstances in the intestines, even in the liver, on the spleen. Very rare circumstances of ectopic pregnancies that are known as abdominal pregnancies. Now, the most common types of ectopic pregnancies are the ones that grow inside this tube, otherwise known as tubal ectopic pregnancy. Now, mind you, this uterus is composing of muscles that are very much extensible, that can expand during pregnancy, allowing for a baby to grow up to 40 weeks or 9 months, as we normally refer to that in layman terms. However, this tube over here, where most ectopic pregnancies will occur, is a very restricted structure. It might be able to allow for minimal expansion. However, it reaches a certain point where it cannot expand any further, and the limit of its elasticity has been exceeded, and you find now whatever pregnancy that has now been growing over here will lead around, or will bring about a rupture of this tube, a bursting of this tube, which is quite a dangerous affair, where we will find now this patient or this pregnant woman with the ectopic pregnancy that is grown inside the tube starts bleeding, and most of the times she's going to be bleeding within the abdominal cavity, to the point that some moments where some women might lose even liters of blood before they even come to us, which means their lives are very much in danger. So what are the signs of ectopic pregnancy? You might have very non-specific symptoms, vague abdominal pain down there for a woman, particularly someone who's missed their period. Sometimes you might find a bit of bleeding over here from below, which some women might confuse that to be normal period, while in actual sense they have an ectopic pregnancy and they have that bleeding. A number of times you'll find women, especially those who've bled a lot, they come to us very weak because they've lost a lot of blood inside their abdomens. They are weak, they are dizzy, they have headaches, they can't even walk because of abdominal pain and swelling. So those are the general signs and symptoms of ectopic pregnancy. So what are some of the ectopic causes, the most common causes of ectopic pregnancy? The leading one, particularly in our population, is during that process that I described earlier of a normal pregnancy forming and transporting to grow inside the uterus. If anything impairs that transport of the fertilized ovum to reach the uterus and grow inside, it means it will actually grow outside the uterus. Anything that impairs the transportation of that fertilized ovum to go inside the uterus and grow inside there will actually increase the risk of these women getting ectopic pregnancy. So what are some of these things that can impair the transportation? Number one, pelvic inflammatory disease, otherwise known as PID, that is infection of the female genital or reproductive system, particularly either the uterus, the tubes, or the structures that are around the tube. So if you have that infection, that is pelvic inflammatory disease, it's an infection that might indeed heal in the future. However, it might heal with scarring of this tissue, and if the tubal tissue. So if the tube is scarred from these infections, it means now the transportation of a fertilized ovum might be impaired, so that you have these women having a higher risk of forming an ectopic pregnancy within these tubes, as opposed to someone who's not had PID, that is pelvic inflammatory disease. So one of the leading causes is PID, pelvic inflammatory disease. Another cause could be a history of an ectopic pregnancy. So for a woman who's had an ectopic pregnancy in the past, there is also a risk factor for another, what is known as recurrent ectopic pregnancy. Another one, is tubal procedures. So someone who's had, for example, they were told they have blocked tubes and someone went in and tried to fix the tubes. So all those procedures that are known as tuboplasties or repairing of the tubes sometimes might increase the risk of this woman eventually getting ectopic pregnancy in the future. Conditions such as gynecologic conditions such as endometriosis, which is quite rampant these days, are also known to increase the risk of ectopic pregnancy, because that is a condition where women tend to have adhesions and tissues that is around these tubes that brings about the blocking of these tubes, which means the transportation of that fertilized ovum in a timely manner to reach the uterus to grow inside there might be impaired. So those are some of the risk factors for ectopic pregnancy. Yeah. Thank you.